Cure International operates these 10 hospitals. The majority of them are focused on orthopedic care for children. And so there's only a couple of hospitals that are currently offering this neurosurgical service. Uganda actually is exclusively a pediatric neurosurgical center. Our hospital in Zambia, in Lusaka, offers both orthopedic care and neurosurgical care. So those are the two hospitals that offer pediatric neurosurgery and are doing this type of treatment for hydrocephalus. In addition to the two hospitals that Cure has, we have the Cure Hydrocephalus Surgical Training Program, and that program was set up and designed to equip other surgeons from other countries to be able to provide this treatment for hydrocephalus. And so to date, we've trained 26 surgeons from 18 different countries on how to provide the ETV-CPC treatment for hydrocephalus. They come to our hospital in Uganda. They spend 2 to 3 months with our team on how to do this procedure. They demonstrate capacity to do it, and then we equip them with the equipment. They need to go back to their home hospitals and provide this same service for children in their home countries. Great question. It's a bit of both. So, I mean, right now the program is really set up for low resource countries who have this population that they need to provide service for. With that being said, we have gained a lot of attention now that we've done this, for 10 years and we've had such success with it. We are attracting interest from the American neurosurgical community. So we've had about a dozen qualified American pediatric neurosurgeons who have come to Mbale, Uganda, and spent a few weeks with our team there on learning how to provide this treatment for children in the U.S., which is a little bit unique. It's not often we have American neurosurgeons coming to Uganda to learn how to do a treatment for children back home in the United States. But we believe, as they do, that if we don't need to place a shunt into a patient's head, then we should explore that, and where it's appropriate, we should do that. Well, I can speak most specifically about Uganda. This is probably true for the rest of our hospitals as well. These are fairly high volume hospitals, and so in Uganda we're seeing about 5,000 children a year. We end up providing about 1,200, 1,300 surgeries and for children. So that breaks down to about 6 to 7 cases per day. We work on a Monday through Friday. Let me rephrase that. That breaks down to about 30 cases a week, and that's a high volume center. I think most neurosurgeons would tell you 30 cases in a week. We have 3 ORs, 2 that are usually running at one time, and it's a busy neurosurgical center. By comparison, here in the U.S., a busy neurosurgeon here may see between 5 and 10 cases in a week. So it is a busy center. It's a high volume center. However, with that being said, I mean, most of our cases are treatment for hydrocephalus or spina bifida. We don't handle a lot of trauma, and we don't see a lot of tumor cases, although we do handle about 50 cranial tumor cases a year. So those are typically more time intensive, more labor intensive. Most of the surgeries that we provide are 60 to 90 minute surgeries. It allows the turnaround to be a lot quicker. They're less invasive than other types of neurosurgical cases. We do. I mean, most of our hospitals do charge a fee. It's a nominal fee in many cases, and it's often on a sliding scale. So the goal is, in many of our hospitals, is to create ownership on behalf of the family for that patient's care. And so there is a transaction that takes place, and it allows us to be able to offer a service for a fee. But it's an imperative, and all of our hospitals do this, that the care is accessible and it's affordable. So no child that needs treatment at a Cure hospital is turned away because of an ability or inability to pay. Some families are able to contribute a percentage of what it costs, and others are able to contribute more. We do have an exception in one of our countries where, because of the NGO laws in that country, that require us to not charge patients. But for the rest of our hospitals, we do charge a small fee, but we make sure that nobody is turned away and everybody receives care that needs it. Yes, I mean, absolutely. So there is currently right now the Cure Hydrocephalus Surgical Training Program. We are receiving funding for that program from the private sector in the United States. And it is something that we work hard to be able to package and deliver to a donor community. And it is, I think it's attractive to a lot of folks. We're building capacity. We're offering a novel new treatment for the most common pediatric brain condition in the world. As an organization, we're aware that we want to become more sustainable over time, and we're taking steps to, with each of our hospitals, to be able to realize earned income opportunities in their areas. What the reality is that we also need to continue to work toward helping provide funding from the private sector here in the United States and countries and countries in Europe and the UK. About half of our income needs are raised through fundraising efforts here in the United States, mostly all from the private sector. We do receive support through the U.S. government, primarily through the American Schools and Hospitals Abroad program under USAID. That's primarily used to help with capital items, facilities, and equipment. No, I believe that there are. I mean, I think that we're looking at how to create income opportunities for our hospital, receiving contributions from patients, but still making sure that our services are accessible and affordable. Government does play a role. I think government can help subsidize care, and I think we're continuing to look for opportunities to realize income through the services that we can offer without creating a barrier to care. So 8 years ago, when I arrived in Uganda, we were only earning a couple $1,000s a year from contributions, and that was mostly through well-wishers, people just giving us money because of the service they received. We weren't necessarily charging fees consistently, but beginning in 2007 into 2008, we started requiring our patients to contribute something, even if it was $10. We wanted to make sure that, however, whatever their situation was, that we were going to take care of their children, but we also wanted them to conduct a transaction with us, to take ownership of that child's care. So what started as an enterprise to create ownership of healthcare for that child or that patient has turned into a new sustainability model for us, in that what started out as a $1,000 a month, $2,000 a month, revenue generator for that hospital is now, last year we earned $125,000 from the same population. So we're talking about 5,000 outpatients and about 1,200 inpatients. The profile of those patients is consistent with where it was 8 years ago, but that population has only grown. In fact, we've doubled our surgical volume from about 750 cases a year to nearly 1,300. We've increased our outpatient volume by about 50%, from about 3,000 outpatients a year in 2007 to over 5,000 this past year. Our numbers have grown. The types of patients we're seeing are pretty consistent, where they come from, their demographics, but they're now contributing significantly more toward the cost of care. And that is accomplishing two things. It's creating ownership, value for them, and it's creating a better sustainability model for the hospital. So we've actually realized a lot more income through patient contributions without losing our patients. We've actually increased the volumes. The quality of care is consistent, and where our patients are coming from is the same as they were 10 years ago. It's primarily from rural parts of the country, from lower income families, and from a lot of young mothers bringing their babies. So. Yeah, I think it's a result of awareness that creating value. So people have now, after doing this for 8 years, the public, or the communities in which we serve, have realized that there's an exchange for value. So they're paying for a service, and we're providing a high quality service. In the beginning, when we introduced this model, there was some pushback And it wasn't always easy, but I think we were trying to change from being a charity-based hospital to creating a more sustainable hospital that was offering a valuable service. And there definitely were some, 2008 into 2009, we had some challenges. But today, it's understood that all of our patients coming in are contributing something. None of those patients are turned away. And the culture has changed in how they perceive healthcare. So in the backdrop of this is public healthcare systems and the idea of having free or subsidized care. In Uganda, people know what they're getting, and so they go to a public health center, and even if it's free, the quality of care is not what they believe it should be, and they know that in order to receive something of quality, they're going to have to contribute something toward it, and that's what we're trying to provide.